diagnosed as exercise-induced asthma.
Yeah.
And he has all of those symptoms besides. Could they be related?
Yes, no, you can certainly, laryngopharyngeal reflux and vocal cord dysfunction can be mistaken for asthma. So you might be called asthma and you actually have this other condition. And what clues you into that is that everything looks like asthma, but when you take the asthma medicine that the doctor says is going to work so well, and it doesn't even work, or it only works a little bit, or it only works sometimes. Or you can have both of them. People with asthma will frequently have a reflux problem and may have a laryngeal problem also. And then when you feel the symptoms, you're not quite sure which is it that's causing the problem this time, or is it both. And it's often very difficult to figure it out. So you could have exercise-induced asthma or regular asthma. You could have reflux-induced vocal cord dysfunction, or you could have a combination.
There's allergies and sinusitis all the time.
And often the only reasonable strategy is to just treat the heck out of everything, because you can't figure out which problem is it this time that's caused by something.
With the laryngeal asthma, are the lung functions different on these folks?
Another thing about laryngeal asthma is that often when you do the pulmonary function test, it's normal. So, and you think sometimes even patients are wheezing. They go in there and they're wheezing, and then you do the pulmonary function test and it's normal. So this doesn't make any sense. But that's another clue that you might be dealing with laryngeal asthma. When you make that forced maximal effort, the larynx opens up frequently, even though it's partially closed when you're doing normal breathing.
And what's the trajectory for those patients in terms of their lung functions? Not necessarily testing.
Lung function, if laryngeal asthma is the only problem, lung function will usually be well maintained because the lungs, there's nothing wrong with the lungs.
So they just have this discomfort.
Although people who they have difficulty breathing, although if what's coming up from your stomach gets this far and it irritates the larynx, very often the larynx will start not moving correctly. And the thing that catches your attention is when it's closed and it's supposed to be open. But what also can happen is it can be open when it's supposed to be closed, and some of that reflux material can come up and over the top and go down into the lungs. And if it's a little bit, it can lead to bronchitis, and if it's a lot, it can actually cause pneumonia. So the reflux can cause more serious lung problems if it goes on and it's unrecognized. You don't pay attention to trying to control it.
Does that cause swallowing as well?
Yes. Yeah, well, the problem with swallowing can result from either irritation of the larynx where it gets swollen, or irritation of the esophagus up to the top.
Getting back to the lung function, what's the normal capacity of a person's lung? How many cc's? And if you lose 30 or 75 a year, you're on sort of a one-way street to eventually ending up with oxygen.
Fortunately, that's a relatively small percentage of your total lung capacity. My vital capacity is about 4,700 milliliters. So start at, excuse me.
So
That decrease he was speaking of was what, 0.75 milliliters, right?
Liters, well, like 4.7 liters, so
Yeah.
4,700 milliliters.
Right, but the part you said we lose years.
You lose about 30 milliliters.
Milliliters, a tiny, tiny, tiny bit.
Right, so keeping the units the same, 4,700 is the total volume, you lose about 30 a year. Now, that's if you're starting from normal, but your lung function, the size of your lungs depend on the size of your body and several other things. We have what's called a predicting value. Whenever you get a pulmonary function test report, it has a column of numbers that have your values and then a column of numbers that show the predicted value. And the thing that goes into coming up with a predicted value is age, sex, height, and race. So they take those four characteristics of every person and put it into a formula that comes up with what is perfectly normal for a person of your description. And then you judge from there if you're two standard deviations on either side of the normal predicted value, that includes 95% of the normal population. And then you see where you fall. If you're too small, if your FEV1 is further than 2 standard deviations away from the average normal value for a person of your description, then we say, then you know that that's reliable information that there's something wrong with the lungs.
Just to pursue this one
Okay.
step further, you mentioned that some people would have as little as 500 and they'd function all right, and some would have 800 and they would have trouble.
Yeah.
Now, are we talking about this same volume, the same cubic centimeters
Yeah.
that you measured?
Yeah, those numbers, the example that I was using was for the FEV1. The FEV1, those are the same milliliters.
And at what point are the prescribed oxygen, and how does that
Okay.
help this?
Oxygen, you prescribe oxygen when people have low levels of oxygen based on the pulse oximetry testing or based on a blood gas testing. So, although it's generally true that the sicker you get judged by pulmonary function, the more likely you are to need oxygen, it's not always so. Some people with only mildly abnormal pulmonary function need oxygen, and some people who have very abnormal FEV1 still don't need oxygen. So it's really a separate assessment. You need to check the pulse oximeter, and sometimes you check it. You'd like to know what your oxygen level is when you're sitting still, when you're active, exercising, and when you're sleeping, because it may be normal at one time and not normal another time. So it's very common to measure an overnight pulse oximetry where you wear the gadget on your finger overnight and have a record that goes all night long to see what happens when you're sleeping. A lot of people get hypoxemia at night, and even if they're normal, when they get it measured and they check it at the doctor's office. And then if that's the only time you're hypoxemic, then that's when you need oxygen. You have to prescribe when you start to sleep.
I have a question. Just, my father-in-law
Hey, Mom, I'll have to
has
call you back.
COPD, and he's on all the medications that can be prescribed to him. Everything that can possibly be done to help him is, being done. But his pulmonologist suggested using his BiPAP machine in the middle of the afternoon for a little bit while he's sitting and watching television or doing something to try and get more oxygen into his lungs and his organs. I'm just curious, I've never heard of that before. Is that something that more people should be trying if they're feeling a little,
Well,
they
as
need
far as-
something in the afternoon if they've got a BiPAP machine or a CPAP?
Yeah, well, that would be the first question I want to ask is, why do you have a BiPAP machine in the first place? And BiPAP is different from CPAP. CPAP is continuous positive airway pressure, which is almost always given just for treatment of obstructive sleep apnea. And a lot of people with obstructive sleep apnea also have COPD, so it may affect.
The continuous seems to, and I know lots of people who have this problem. It's almost like stick your head out the window and try to breathe when you're going 55 miles an hour. With the CPAP, it's just constant, and they can't even breathe in.
CPAP is not as easy to breathe with as the BiPAP.
The BiPAP is much easier.
Means if you have two different levels of pressure, that it's higher when you're breathing in, and the pressure goes down when you're breathing out. So it's a bit more comfortable to breathe with the BiPAP. The other thing you get from BiPAP is that because there's a pressure difference breathing in and breathing out, it actually helps you to take bigger breaths. So it does some of the work that your diaphragm would have to do if the machine was not helping. And I think that's the reason that it would help to use it for a while during the afternoon. That it gives your diaphragm a rest so that it can then benefit from the rest and be stronger when you take the BiPAP off.
I will present it to him that way so that he actually does it a little more often. Thank you.
Yeah, that's motivating. It always helps people to use something if they understand how it works. I think that's a good point.
Well, back to COPD
Yeah.
and emphysema. And how you have your light bulb moments. And normally, when those of us that are having any
Well, one of the problems that can be a big problem both in COPD and in asthma, and even more than that, bronchiectasis. We didn't talk much about bronchiectasis, but is mucus. And when your lungs are irritated and inflamed, they produce mucus. And mucus can be anywhere from watery, in which it's clear and has a consistency of almost water, although it's always a little bit slimy if you touch it. And it can be, at the other end of the spectrum, it can be more like yogurt, or it can be really thick. It can even be dried out and even more solid than that. So it can be easy to cough up, or it can be stuck down there. It can be, you can feel that it's down there, and you get it plugged up, and you cough, and nothing comes up. And so Mucinex is a drug that contains guaifenesin, which is a reliable way to thin out the mucus. And it works to some degree. Some people it works great. Some people it works a little bit. So it's always worth a try if you have a problem with thick, sticky mucus, to try to liquefy it, add more water to it so that it's easier to come out. Once you have made mucus, what you'd really like to do is to get it to come up and get out of the way. So if you have a problem with excess mucus, as some people do who have COPD, but nearly everybody does who has bronchiectasis, then you need to set aside some time during the day to specifically work on clearing out the mucus. And in that time, it might be a matter of getting into the right posture. Then you have learned is the position that brings up the most mucus because of just the way the lungs are, where the damage is in your lungs. If the damage is in a portion of your lung that you put uphill, the mucus will run downhill and then you'll cough it up. So postural drainage is important. Sometimes someone pounding on your back, doing chest PT, sometimes using a device like the vest, where you put on a gadget that wraps around your chest, that's attached by hose to a machine that uses air pressure to essentially have somebody put you in a bear hug and go. And it shakes your whole body, vibrates your whole chest, and it will shake loose the mucus so that after keeping that on for 5 or 10 minutes, then you can cough up more mucus and get it out of the way. Once the mucus is produced, what you really need to do is get it up and out of there so it doesn't plug up your airways.